Thank you very much, Claire. And good morning, everyone. Thank you so much for joining us today for today's conversation about COVID, the new normal. I'd like to just start the session by acknowledging that I am on Noongar Boodja, the land of the Whadjuk people of the Noongar Nation, and I pay my respects to elders past, present and emerging. As a recent migrant, I always consider myself very fortunate to be able to call this land home. But of course, all of us, apart from the Indigenous people, are migrants, and this land is, was and always will be Aboriginal land. So we're joined today, if there any housekeeping, I think Claire's covered it all, but Claire, how do you turn on the live captions if you want those?
So if you go to along the bottom, there should be an option that says either more, and then you click on live transcript and it will say request live transcript.
Great, thank you. And like Claire said, we're going to try and stay on mute for the session if possible, please, because we've got quite a lot of people. You will have an opportunity to ask questions of Professor Waterer after his presentation, and we'll ask you to be popping those in the chat. So we're joined today by Professor Grant Waterer, who is, hold on, I've just got to find my area Director of Clinical Services of East Metro Health Service and Professor of Medicine of University of Western Australia. You see now why I had to write that down, so my apologies. And Professor Waterer did a session for us back in March, which was very well received because he's really great at explaining things. And we've asked him to come back because things have changed quite a lot since March, it's fair to say. You know, we've got less cases, less deaths than there were, more medicines than there were back in March to treat COVID, but largely less restrictions. So things moving on in society in terms of living with COVID. However, we're all still very much affected by COVID, either at the possibility of getting sick or isolation, and also particularly for very vulnerable people. It can be a challenging time as there are less and less public health measures. So still a very important subject matter. And also the other thing to mention, of course, is people who didn't consider themselves medically vulnerable might be suffering with long COVID. So we're aware that there's still a lot of questions out there, and we've asked Professor Waterer to come along today and give us a bit of an update. So I will hand over to him. Thank you.
Thanks, Nadine, and thanks to the Consumer Council for the opportunity to talk again. Let me bring up my slides here. So let me also acknowledge that the Whadjuk people of the Noongar Nation and East Metropolitan Health Service is very proud to be a major carer for Indigenous people. There is a lot of change in COVID, and I know there's a lot of confusion, and to be honest, things will continue to change. In my presentation, I'm going to cover just some of the things that I think are very important that people are not understanding, and even when I present to general practitioners, and even other specialists, some things that people aren't perhaps aware of, that then when you are, suddenly everything makes sense. So I'm going to talk about what's happening with the vaccines. Again, who's at high risk, what should you do if you're at high risk, and what should we still be doing about RAT tests. So one of the things I hear is that, you know, people are still catching COVID, and COVID's still around, we're all being vaccinated. We're hearing that people are getting reinfected. So, you know, are the vaccines working or not? It's really important to understand that with COVID, there are different stages of infection. So in the first stage, you get COVID into your nose or your mouth or your throat. And this gives you the runny nose, the sore throat, the bit of a cough, some fever and headache, basically a bad cold, or anything from a mild cold to a bad cold. And because you also swallow your spit and it goes into your stomach and your intestines, you can get some nausea, vomiting, some abdominal pain, even some diarrhea. Those are all what I would call local first stage of infection. Now, our immune system isn't really very good at developing immunity to that first stage of infection for any virus. Well before COVID, we knew that people would get the same virus infection every 3 or 4 years, whether we're talking about adenoviruses or Coxsackie viruses or coronaviruses like COVID. Our immune system isn't that great at giving us immunity to this cold aspect of it, the local infection. And when we do get some immunity, it isn't very long lasting. So we know that even before COVID with coronaviruses, for example, immunity would last 6 to 12 months, but then people could get the infection again. But what's important is that to get sick, the virus has got to get into your blood. And it's the virus getting into your blood that causes all the serious problems like lung failure, like in COVID, like clotting, like the heart disease. And our immune system, whether that's from naturally occurring infection or from vaccination, is really excellent at preventing this second stage of disease. And our immune system gives us very long-lasting protection to this bad stage of disease. So, and then if it gets into your blood, then it can go on and cause all kinds of other problems. So the way I kind of look at it is like this, is that in our nose and our throat, if you imagine this first box is the first barrier that the virus has got to get into. And our immune system is okay, but it's not so great at preventing this first stage of infection. But our immune system is very, very good at building up immunity in the blood and stopping the virus from getting into that kind of second stage of infection and causing really bad disease. And that means that you never get into the other stages of disease where you're really talking about high risk of death. And if we look at what's happening worldwide, this is data from the United Kingdom. And what they're looking at here is that if you had 2 doses of the Pfizer vaccine, you can see here that over time, so this represents you've had the 2 doses 2 to 4 weeks ago, 10 to 14 weeks ago, more than say 6 months ago. For Delta infection, for symptomatic COVID, so just getting a cold, getting any symptoms at all, you can see that it did wane over time for Delta and much more so for Omicron. But if you'd had 1 booster, for Delta, it was very, very well maintained immunity. But for Omicron, it was starting to drop off again towards the 6-month mark, which is why the recommendation came out for the extra booster. But if we look at more severe disease, what you see is for getting any infection, a booster less than 3 months, 45% protection, 4 to 6 months, 15%, more than 6 months, very little protection. But if we get down to more severe disease, like disease causing hospitalization or disease causing death, what you can see here is that the vaccines maintain very high levels of protection for a very long time. And that's because the vaccines give us very high levels of antibodies in the blood, which stops that virus getting into the blood and causing bad disease. So both our natural immune system and our vaccines are not very good at stopping us from getting a cold, but they are very good at stopping that cold from becoming severe fatal disease, leading you into an intensive care unit, leading you to be hospitalized. And that's really important if you think about what is the future now. The future is, unless there's some completely novel way of giving us immunity that the body hasn't developed over evolution, we're not going to stop COVID from causing people to have a cold occasionally. But we will be able to stop most people from becoming very sick. And in actual fact, even now, you would have to say with the vaccines and the efficacy of the vaccines we have, COVID is much less of a threat now than, say, for example, influenza is, because our influenza vaccines are not this good. The main issue with COVID is it's so much more infective, so it's spreading faster. But from a risk of getting severely ill, with our vaccine strategy, the risk of getting severely ill is greatly reduced. So our vaccines are working. They're stopping you from getting very sick. They're stopping you from ending up in hospital, getting into an intensive care unit and dying. They just don't protect for very long periods of time against getting a cold and getting a bad cold. And so our strategy moving forward that regulatory agencies and governments will have to tackle with is, how often do we vaccinate to protect against severe disease, given that really it's going to be impossible to prevent people from getting a cold occasionally if there's COVID circulating in the community, because we simply don't have a strategy that's going to prevent that at the moment. So what now for boosters? When we know how long that second booster gives protection for, and there's reason to think that each booster, the protection would last a bit longer and a bit longer, we'll know when a third booster might be necessary. Equally, there are new vaccines shortly available that have been reformulated, and they're a mixture of the old vaccine. Both Pfizer and Moderna have new mRNA vaccines that are a mixture of the original vaccine and new formulated vaccines to give better cover for Omicron. And those will be out shortly, and our regulatory agencies will look at the evidence for those and will decide when those vaccines should be rolled out, and whether that's this year or whether as Omicron drops down, we might wait until after summer, anticipating that you get the most coverage from these vaccines in the first 3 to 4 months. You might want to have it in actual fact pre-winter rather than in spring. I think we'll wait and see what the regulatory agencies say based on the data and based on whether new strains emerge this winter coming out of the Northern Hemisphere winter, and whether that gives us a new out of season boost of COVID. But we will at some point get these new vaccines and all be having them. But I think the decision will be based on preventing severe disease, not stopping people from getting a cold. It's just not going to be possible to stop everybody from getting some symptomatic COVID when it's circulating. Just as like it's impossible to stop everybody from getting some influenza or some of the other viruses that cause colds. Our ordinary immunity doesn't protect that from that. Our vaccine immunity doesn't protect from that. So it's unrealistic to think that we can completely stop all COVID. What we can stop is most of the severe, nasty disease. So has anything changed in who's at risk from dying from COVID? This is deaths in COVID in Australia from recently. And what you can see here is still, this is very much an age-related mortality disease and different from influenza. So in influenza, you would often see a peak in younger children and then this age-related change. But very much with COVID, it's age, and you can see here how dramatically it picks up from 60. But also males, slight predominance, and the over 90 is simply that the difference in age here is that there are more women live longer than men. But this is every infectious disease we know of, women are actually more protected than men. And that is probably because for most of our evolution, women had a high risk of dying of infection in childbirth. And so along with female genetics, there is actually a higher protection against infection for most things. Pneumonia, for example, men are much more likely to die than women. But you can see here it's age and with a slight predominance of men. What's really important is how drastically vaccination reduces the risk. So this is some data from a bit earlier this year from the University of Queensland. And this is mostly Delta data with a little bit of Omicron. But what you can see here is if you look at vaccinated women, purple box here, they really only start to appear in the over 70-year age group. And if you look at the difference in mortality rate in terms of deaths per 10,000 cases for unvaccinated women in green versus vaccinated women, And if you look for the same for men, you can see here the drastic difference that vaccination makes. That really, you're not seeing deaths in vaccinated people under the age of 70, and this dramatic difference between vaccinated and unvaccinated. So absolutely no question that vaccination is dramatically reducing the risk of severe disease. And again, that gets back to the point I was trying to make, that there's two phases of COVID infection: the initial bad cold, local airways disease. And, you know, a lot of people get that, but vaccination is stopping that second phase of virus getting into the blood and causing lots of bad disease. So age is the overwhelming one. And certainly from 70 and up, it's a logarithmic curve. Significant obesity, diabetes, although the risk with diabetes is almost eliminated with vaccination in studies that have been done. If you have underlying heart disease, but again, vaccination seems to very well protect against that. People needing dialysis, people with chronic liver disease. Interestingly, people with chronic lung disease have only a very, very slightly increased risk. And asthma doesn't really seem to significantly increase the risk of death from COVID. It does increase the risk of hospitalisation because COVID can set off asthma. But asthma in itself doesn't really seem to be a risk for mortality. And then anyone who's got any severe compromise of their immune system, that that would be the same for any infection, but also because in fact they don't get the same protection obviously from vaccines. And that's people, for example, with HIV infection, those who've had organ transplants, bone marrow transplants, those who are on significant chemotherapy. What do you do if you've got those risk factors? The first thing is keep up to date with the recommendations for boosters. And don't forget to get your influenza and your pneumonia, pneumococcal vaccinations as well. For my patients now, I'm actually more worried about their risk of influenza than I am of their risk for COVID, and that they won't get their influenza vaccine because they'll forget. And so I think keeping up with your influenza vaccine is just as critical to keeping healthy. Having your health as well controlled as possible. So if you've got diabetes, you get your diabetes as well controlled as you can. If you've got high blood pressure, you get your high blood pressure as well controlled as you can. If you've got emphysema, you're on you're on your medicines and you're taking them regularly. Keeping up with exercise and having a healthy diet as you can. It's hard to put a percentage on what benefit that gives you, but there's no question in study after study after study, the more cardiovascularly fit you are, the more likely you are to survive any significant illness. And that, the healthier the diet you have, the less obese you are, the better. You should, and I'll talk about the antivirals in a second, you should ask your GP or your specialist if you should be getting one of the early COVID antivirals if you do get COVID. And I'll talk about the indications for those in a second, and they're two new medicines, one called Paxlovid, the other called Lagevrio. You should do what you can do to reduce getting a large exposure. So this is the other thing about vaccination and immunity. Immunity is a balance between how quickly your immune system can respond and how quickly the virus can grow. If you get only a tiny amount of virus to start with, your immune system has a head start. If you get a large amount of virus to start with, then the virus has a head start. So what you don't want to do is get a very large amount of virus when you get exposed. So that means, if you go to lots of big gatherings when there's COVID in the community, avoid those gatherings if you can. If you have to go, wear a mask, wash your hands regularly, and avoid people who have symptoms, and tell people that if they've got symptoms to keep away from them, because anyone who's got active COVID will be shedding a lot more virus than someone who's got very mild disease. Sorry, I'm going to cough, so I'm just going to pause my mute for a second. That's not COVID, and you can't get a computer virus from me. So it's really about protecting yourself from getting a very large dose of COVID, because if you get a small dose with the vaccines, and if you've had COVID, your immunity will kick in. And as long as you don't get an overwhelmingly large dose, which is why we're very concerned in hospitals when we do things to people with COVID, because potentially we can get a very large dose, which is why we use all the extra bits of protection. But, you know, in the community, all you really want to do is stop someone from coughing all over you when they've got active COVID. These are all sensible things as well to stop you from getting influenza. Okay, so there's influenza in the community. Anything that we do here for COVID is going to stop you getting all the other kinds of virus infections that can also be bad for you. So these are all sensible things to do, regardless if you're getting on in years or you've got some comorbidities. The rapid antigen tests. So everyone knows that these tests are not perfect, but they generally are, if you do them properly, they generally are positive if you've got significant disease. So if you've got high risk factors and you want to test because you're developing symptoms or you've been exposed because you're going to be eligible for an early treatment, they are still absolutely worth doing. Equally, anyone who's got active respiratory symptoms like cough, fever, sneezing, sore throat should not be going to work or socializing regardless of whether their RAT test is positive or not, because you could have influenza or any other virus. Okay, so I think one of the things that people have underappreciated in the past is how much damage we cause by wandering around, going to work when we've got active infections, coughing and sneezing, going and seeing elderly people, and then exposing them to influenza or other nasty viruses, and there are plenty of other nasty viruses. So everything that we now are doing for COVID, like not going and seeing people when we've got active symptoms, like staying away for a few days, after the symptoms have stopped, if we can, to try and maximize that period where we're giving ourselves a chance to not be infective. That should apply for any respiratory illness you have. Now, your work or your residents may require you to do a RAT to say if it's COVID. That's perfectly okay. And if it's absolutely critical that if you've had a couple of RATs and you've been exposed or you've got symptoms, it is worth getting a PCR if you have high risk factors, because again, that may lead you to early antiviral treatment. So if your GP or your specialist had said to you, look, if you get COVID, I would want you to be on one of these antivirals. If you're worried that you've got COVID because you've got some symptoms, you've had 2 negative RATs, probably getting a PCR is worthwhile, just because the RATs do have aren't quite as sensitive as the PCRs. What is important to know is that RATs and PCRs don't tell you if you're infective, okay? So the real problem is, as you know, we've reduced the period of isolation. And while your first RAT or PCR tells you that you've had COVID or you've got COVID, those tests can remain positive for some time, weeks. Just because you've got a positive test at 10 days doesn't mean that you're still infected. That could all be dead virus. The only way to know is to do very expensive culture experiments that we simply don't do. And so one of the questions that constantly comes up is, okay, I've had COVID. I'm at 7 days. I don't have any symptoms anymore. Is it okay to visit my 95-year-old mum who's in a residential care home? The answer to that is that we don't have the data. And the only advice I can give you is that we know that the amount of people who are infected at 5 days is more than at 7 days. And at 7 days, it is more than at 10 days. And by 14 days, very, very, very few people are still infective. I think that this is something that if it was in my situation, I would probably wait for at least 48 hours of being asymptomatic until I went and saw someone who I thought was at high risk from COVID, and I would wear a mask when I saw them. And I would, if I could, and this is, there's no absolute guidelines on this. If I could, I'd probably try and wait at least 7 to 10 days, but obviously sometimes you do need to see people. So my kind of working guidance of thumb is at least 48 hours of not having symptoms before I'd go and see someone. And if I could, I'd try and wait the full 2 weeks if they were high risk. There's no evidence to support that. It's very difficult to find any consistent guidelines around it. So it really is a kind of a working rule of thumb of how much do I need to see that person in person versus, you know, what's the risk? And obviously situations vary. If it's someone who's living at home who, you know, needs your support, well, then obviously you're going to need to go. If they're in a residential care setting where they're getting some support, maybe it's just better to wait an extra 48, 72 hours and, you know, just touch base by phone or Zoom. And I know that's not an absolute answer for people, but I don't think there is an absolute answer to that question. I think it's really about balancing the risks and knowing that, you know, certainly after 5 days, the risks are dropping. After 7 days, they're dropping dramatically. After 14 days, they're probably not there at all. So, you know, there isn't a test to tell you when it's okay or not. There's no such thing currently. I don't know if I mentioned the, I'll come to antivirals in a second, I think, and if I don't, I'll talk about it. What about long COVID? Long COVID is a real thing. The frequencies are varying enormously in the literature. What's clear is that it's overwhelmingly when we can find a cause. So when we can find some lung disease or some heart disease or some brain disease, where we can find some pathology, it's overwhelmingly in the unvaccinated people. Very, very few vaccinated people have pathology that we can find. Now, that doesn't mean that there aren't people who are getting chronic fatigue-like symptoms, the brain fog, who have had COVID and have been vaccinated. But in those people, it's very, very difficult to find any pathology. And that means that the treatment for it really is rest and then exercise and diet and getting on with your life, because there is no treatment that we can offer at the moment because there's no test to tell us what's wrong and there's no test to tell us which treatments will work or will not work. Again, what we know is that it's mostly those who have been to the intensive care or been hospitalised. Very, very few vaccinated people who've had just COVID that's led them to have a few symptoms and been at home are developing significant long-term COVID. I mean, it's in the 1 in 25 to 30,000 range. Whether you get long COVID or not doesn't seem to be particularly influenced by age or chronic conditions, other than if you have age and chronic conditions, then you're more likely, of course, to be hospitalised. Any of these symptoms that are described can be caused by lots of other diseases. And just because you had COVID doesn't mean they're due to COVID. So I think you see your GP because there may be other explanations for the symptoms, but it's important to know that there are no drugs that help long COVID, okay? The most effective interventions are time, exercise, a good diet, and a healthy sleep pattern. All right, so antivirals, and I should have put a couple of slides in here. So there are 2 antivirals that are now out. The indications for the antivirals are people who are age 70 or over, or people who have significant chronic, over 30 who have significant multiple comorbidities. The reason for those indications are that the antivirals don't actually make a large difference in vaccinated younger people. In fact, the difference is very, very tiny. The antivirals are not like antibiotics, okay? It's not like a bacterial infection where if you don't get the antibiotic, it will get worse and worse and you've got to have the antibiotic to be cured. The Antivirals make a very small difference, a significant difference, but only a small difference. There are two. The Paxlovid is a combination of two antivirals, and while it has the best evidence for effect, it has a lot of drug interactions, and there's a whole bunch of drugs that have to be stopped, and it becomes quite challenging in people who have a lot of comorbidities to use that drug. Then the second one, molnupiravir or Longterm, it has a lot less side effects. They're quite large tablets. You have to take 8 a day, and it probably has slightly less efficacy. So these are drugs that, if you're at very high risk, so if I was very elderly, certainly getting into my mid-80s or higher, or I had a lot of comorbidities and I got COVID, I would want to take them. But they are not magic drugs, and they are not. It's not a life or death situation with these antivirals. They make a small difference, but they're not a substitute for vaccination. And if I could, I would say that if the antivirals give you protection of 1, vaccination gives you a protection of 99,999. Okay, that's the weight. That they are a useful add in, particularly in people where we think that vaccinations might not be as effective, but they are not a substitute for vaccination. So I know there are lots of questions, and I'm going to stop there so I can try and answer those questions.
Thank you very much, Professor Waterer. So I think staying on antivirals, we did have a few questions about antivirals. Do the antivirals have side effects?
Yes. So Paxlovid, as I said, has a lot of drug interactions, and most of the drugs that many people will take, like statin medications, blood thinners, anti-epileptics, antiplatelet drugs like clopidogrel, many drug interactions that cause problems for GPs about what to stop, what's safe to stop, what you can or can't stop. Equally, it can cause nausea, vomiting, diarrhea, and generally makes people feel a little sick. The Longterm or molnupiravir tends to have less side effects, diarrhea being probably the main one. And probably its main side effects is that they're quite big tablets, and lots of people struggle to get them down. Those are the only oral treatments that we have available. The remdesivir, which most people will have heard of in the news, is still only available as an intravenous treatment, and is really used in hospitalized patients. But the recent data from the Paxlovid intravenous treatment would suggest that it's just as good as remdesivir, if not better. So I don't think that we will be seeing remdesivir coming out for an oral treatment. And to be really honest, I think our current generation of antivirals are just okay. They're not amazing. And I think what we'll see is, over time, one of the benefits of COVID is we'll see much better antivirals coming out over time.
Sure, that's great to hear. Thank you. Can I just also ask about the implications of getting multiple bouts of use of the antiviral? So if you get multiple COVID infections, you end up using antivirals a couple of times. Do we know anything about the implications of that?
So there's not a lot of data yet about people who've had it multiple times. I think the concern will be that, so most people will know about Tamiflu for influenza. And Tamiflu got used so widely that now a lot of influenza strains are resistant to Tamiflu. I think one of the concerns about these antivirals is that they really only seem to be having a benefit in people at very high risk. And so we don't want to be giving these antivirals to more people, because the more that it's used in the community, the more COVID will potentially become resistant to it, and then it won't have its effect in the people that need it the most. So I think the most likely implication of using it more often is a higher likelihood of resistance developing. I don't think there would be likely to be cumulative side effects or anything like that based on the way the drugs work.
Sure. Thank you very much. That's great. So we've had a person ask us about the quickest way to access antivirals. My understanding is that you should start the antivirals within the first 5 days of catching COVID. Is that right?
Correct. So you need to be effective. It's not it's not like at midnight on the 5th day it stops working. It's kind of the sooner the better. It's the studies all had as their entry point, you had to have symptoms for less than 5 days. So we don't have data on what happens if you take it on day 6 or day 7. But there's no question that it would be preferable to have it within the first 3 to 4 days if you could, just to start, if you're going to have it. Which is why I think if you think that you might be eligible for it, what's important is to have a conversation with your GP or your specialist about whether if you got COVID, they would recommend you having it, and what's the plan going to be then to access it.
Great, thank you. And so somebody has asked if GP is the best way to get it, or you can get it from COVID Care at Home if you're subscribed to that service. Do you know?
So COVID Care at Home, as far as I know, doesn't prescribe it. That through your general practitioner would be the way. If COVID Care at Home identifies that you might be eligible for it, they will flag that with you for you to seek aid from your GP.
Okay, great, thank you. And can I just ask then, that sort of leads me on to the recent changes in the testing protocols. So PCRs are, I guess, less readily available. And if you're particularly vulnerable and need to get that COVID diagnosis quite quickly, what are the implications of those changes, and have you got any advice in that regard?
Yeah, so I think this is about moving from a pandemic phase of COVID into this is now the rest of our lives phase, right? COVID's not going to disappear from the community for a long time. And, it may still be, H1N1, the swine flu that we had in 2009, it's still circulating in the community. The likelihood that COVID's going to disappear from the community anytime soon is not high. So what then is the strategy that you need? So again, I would say that, in the conversation I have with my patients is, okay, if you're at risk, and I think that you should have these drugs, then I'm going to have a plan. And the plan is, here's the pathology request form that you can have, so that if you get symptoms, you can go to a lab and you can get it, and you don't have to see me. And then if the test comes back positive, this is how we're going to get you the drug. You've got to have a plan. And I think that's the same with any disease. It's the same for someone who's got emphysema. What happens if they get a chest infection? Well, here's the script for antibiotics. Here's the pathology form for the sputum cup. You've got to have a plan. And I think this is where, patients need to work with their GPs and their specialists and come up with the plan for the new normal. And that's, what happens if you're going to go and travel? What should you do? How are you going to handle that? All of those things you've got to now have a plan for.
Thank you very much for sharing that. Yeah, I've done a plan with my GP, and we included, who I would call, access to antivirals, that sort of thing. But that was before the testing change. So I like that idea, is having the pathology request on hand, so that that if it came down to it, you don't have to try and scramble to get a GP appointment and etc. Yeah. Thank you very much. So we've also had a couple of mentions and questions about the prophylactic treatment. So Danielle has said that organ transplant patients can't have Paxlovid, but can get a prophylactic preventative antiviral called Evershield. Can you talk about that a little bit, please?
So there's a medication called Evershield. It's effectively, if you like, an artificial vaccine. It's you get 2 doses of antibodies injected into your muscles, and it gives you sort of equivalent protection, equivalent antibodies in your blood to if you'd been vaccinated. It also suffers from the same problem as vaccination, that it doesn't give you any local protection in your nose. It's only giving you protection in your blood, which is good, stopping severe disease. It also fades over time, as you would expect, and it's got to be done every 6 months. It is very expensive, and its indication is for people who are on treatments that stop them from being able to make antibodies to vaccines. And so I think it will remain in that very specific niche of people who can't make antibodies because of their disease or the treatment they're on. And it will probably also have to modify over time, because as COVID changes, and it will change, there will be more variants, whether they're less infective or less severe or more severe, we'll find out. But it will need to change as well, because it's formulated at the moment for Delta and Alpha, and so it will change too. But it's not going to be a treatment that's available to most people, only those who have very severely compromised immune systems.
Yeah, so it's not going to be widely available. I'm really conscious of the time, and I've got so many questions, I don't know what to ask. So just on long COVID, quickly, do you know if WA has a specialist long COVID clinic, or is that in the plan, or do you not know?
So most area health authorities have established clinics for long COVID. For most things, they're pretty much limited to people where the GPs have done screening tests and found pathology that we can deal with. For most patients who simply have symptoms without pathology, it's going to go back to the advice that I told you, which is, exercise, gradually building up an exercise program, making sure you've got good sleep hygiene, making sure you've got a good diet, because they're the only treatments that we have available. So really with long COVID at the moment, the approach is, one, to make sure that someone doesn't have pathology that needs treating, whether that's due to COVID or due to something else. And then if we can't find pathology, which is the vast number in the vaccinated people, then it's really about an approach of, well, how do we get you back to normal? Because there isn't a drug, there isn't a treatment. It's going to be down to those basic things.
Okay, great, thank you. And I'm going to use my last minute combining questions about vaccination, about boosters. So the first one is, what now for people who've had their 4th dose over 4 months ago? And then also, what about people who are reluctant to get boosters because they were unwell after their first doses of the vaccination?
Yep.
Any advice there? Thank you.
Okay, so I think there will be a national policy around when to recommend a 5th booster, and I think that will depend on the overseas data on how quickly or how long the immunity is lasting against severe disease with the 2nd booster, and that data is emerging now. Equally, it will depend a little on the newer vaccines and their availability. I think I think everyone would like probably to have one of the newer formulated vaccines for better for Omicron and Delta, and that those will probably be available later this year. And as I said during my presentation, I think there will also be some issues of timing that probably you don't want to give it in December if there's no COVID around until April. You probably want to give it more March-ish. So I think there's people who make these recommendations and set the policies will look at all the data and try and figure out when is the best time to give the community the best amount of protection from that effort of going out. In terms of people who got symptoms before, that's a discussion I'd have with your doctor. I think what's very clear though is that the vaccines don't give long-lasting immunity for years. It's not like a measles, mumps, diphtheria kind of vaccine. And so, the recommendation to give the boosters has been about stopping people from getting very sick and ending up in hospital. And that's kind of the conversation you've got to have with your doctor of, well, what is the outcome we're trying to protect against here, and it will depend on your symptoms, and there are always options, of course, of changing the vaccines. I think it's a very individualized discussion, but when you look at the data of how protective these vaccines are for severe disease, you would want to maintain your protection against that.
Great. Thank you. I'm aware we've already taken a couple of extra minutes of your time and you've got another meeting to go to. So I will just say thank you so much for joining us today and for your great presentation and lots of information. I hope that we've covered most things that people asked. And if we haven't, we certainly at the Health Consumers Council will endeavour to do our best to find answers and get back to people. So yes, thank you very much for your time, Grant. There's been a lot of comments in the chat, if you're seeing it, I don't know, saying just thank you very much for a really helpful presentation. So.
You're welcome, and thank you, everybody.
Bye-bye.